Welcome to another HACSU vodcast, your health and community services union. In this episode, we're going to go beyond the headlines, beyond the sentence or two you might see in the paper or the 20 seconds on TV, and have a serious look at ramping and what is happening in Tasmania. And joining me for this episode of Beyond the Headlines is Cam Johnson, paramedic and also HACSU delegate. Thanks for joining us.
Thank you.
Now, the 60-minute protocol, just run us through how that came about, and then we'll really want to talk about how that's going.
So, as part of our preparations for our last bargaining agreement, we threw the idea around in one of our executive meetings and thought we'd try and sneak it in there, and amazingly, it got through. So, it was our idea, it was our bargaining and our agreement with the government to have it as a condition. We bargained for this in lieu of something else, so whether it was a pay rise or whether it was extra uniform items or extra training. So this is an entitlement. We not only did it for ourselves because ramping on a paramedic is quite stressful. It's turning a lot of us away from the job. A lot of people are moving on because of ramping, and Tasmania has the worst ramping in the country at the moment. But we also did it for patients because it's a patient safety issue. We see time and time again patients with confused care between hospital and paramedic staff, and we've seen on occasion some quite severe and tragic consequences of ramping in the ramping areas.
Pardon my ignorance, but the state government kind of seems like it's their idea. Or am I confused somewhere?
No, they've since taken it as their idea.
Okay.
And it came out in the election that they were introducing a policy to ban ramping. We're not that... we haven't got that much of a simplistic view of it. I think ramping is a very complex issue involving the whole health system and probably, agencies and departments outside of health as well. So it is a start, but they definitely did grab it by the neck and take it as their own idea, and we're happy for them to do that because if it doesn't work, then they will be fixing it.
Well, it's a massive issue that is to be fixed, and there's been a lot of frustration, I know. So basically the protocol is 60 minutes from the time an ambulance arrives at the emergency department. Those patients have to be offloaded within 60 minutes. Where do they go? Because obviously we've got critical staff shortages everywhere.
Yep.
Including nurses, emergency department staff.
So we have the procedure is 60 minutes to hand over. After 60 minutes, there is a series of escalation steps that occur to try and free up some beds, and they're not necessarily in the emergency department but through the wider hospital system. If that means discharging as well, then so be it, but that's up to those managers to coordinate. As far as we're concerned and working with the ED staff, and we'd like to think that we have a reasonably healthy relationship, but this has resulted in some strain, I guess, some pressure, because it is now a policy that we need to comply with. We are looking at escalating through our bosses. They'll come down and they'll escalate through the hospital wider. It has, from week one was fairly testing, and we had some periods where some patients were ramped for quite a long time, and there was some difficulties with the escalation process, and probably some people relying on some older processes and goodwill and cordial, and trying to rely on some I guess goodwill to try and get it to work, but weren't necessarily following the procedure. By the end of the first weekday, we had that issue worked through mostly. So we had the escalation process enacted, and we had beds freeing up, and we had some patient flow. From my experience in the first 2 weeks, there's definitely been a reduction in ramping. There's still patients that are ramped for more than 60 minutes, some for 200, 300, 400 hours. 400 minutes, because we have a little dashboard down there now so we can track them. But it's a lot better than what it was 4 weeks ago when we were nursing patients in our own ward off the side of the ED, and patients were there for 6, 7, 8, 9, 10 hours, probably whole shifts. So there has been improvement, but yeah, you're right. It's difficult to hand over patients to the hospital if there's no beds. But this procedure is hopefully trying to get things speeding along a bit. But ultimately, yes, we need more beds in the hospital. We need more staff, more nurses in the wards, and better aged care, better primary health, so patients aren't coming to the hospital in the first place.
It's unfortunate, isn't it, that there can be friction between departments for this to happen, but it's not your fault, their fault. It's a lack of, would you say, governance? Like, this has been happening for decades. I've spoken with lifetime members at HACSU that are paramedics that have been doing it for 40 years and said there's been ramping for 24 hours. They couldn't get toilet breaks. They would have to go to someone's house and ask to use their bathroom.
Mm-hmm.
They wouldn't.
That last shift.
You didn't. Yeah. You don't have time for a toilet break.
Well, you go on your first job 7 minutes after the start of your shift, and that first 7 minutes is spent checking for critical equipment. And then you're out the door and you go from one job to the next. And I think it was 3 or 4 hours into the shift and I had to go to the toilet. So I asked the patient and they were happy to let me use it, and I did my business. So
it's madness, isn't it? So why has it gotten so bad? Like, how has this been? Well,
it's the demand. So we're under increased demand, whatever reason.
Yeah.
Tasmania's traditionally got ageing population. We've got people with complex medical conditions, lots of chronic issues, highest rates of smoking, I believe. So all these health issues increase the demand on the health system, the ambulance being a part of that system. And the government just hasn't caught up with what that demand is and having adequate resourcing. And we're getting to the point now where we're lucky if we have 50% of our allocated staff on shift, and that's, short-term sick leave call-offs, or people that are broken physically or mentally, people that are just sick of ramping, and having 50% staffing on shifts means you're going from one job to the next, and you're lucky if you get a toilet break. And on that shift, from memory, I think I got my meal break at the would have been started at 7, got it at 1:30 a.m. Didn't get it.
Wow! And in someone that's in an industry where you're saving lives, we need all of our emergency staff to be well rested and fed, and it's just beyond me because, and as you were saying before, it is something that they all feed into each other. I know in the police force, I know some people in there, and they've said to me that quite often they're already at critical levels too, but they'll go to a job and they can't leave till an ambulance comes, and the ambulance might take hours, not your fault, but vice versa as well. You'll go to a job.
Those guys aren't fighting crime, and that's their primary role. Yep.
Yeah.
It all flows on.
And then you could go to a job and you need police assistance, and then you can't get police officers there. Like, it's all feeding into each other.
Yeah, so that's what happens when you don't invest and plan or strategically plan and have enough resources to deal with demand. And we see that now with the police waiting for us to turn up to deal with a medical issue, and then you see paramedics working inside a hospital doing a nurse's job, which is all well and good, but we're not qualified and we've got our own role. So it gets quite frustrating, and like I said earlier, like, people are just over it, and it does their head in. It makes coming to work very difficult, and it contributes to increased sick leave, stress leave. And what people have to understand as well is that it's not emergency work, and that's for police, fire as well. It's not your normal job. So from time to time, mostly it's routine kind of, usual kind of low acuity cases, but from time to time you're going to go to a scene that is going to be some of the worst stuff you'll see in your life, if not ever. And we need to be well rested, we need to be prepared, we need to be properly trained, we need to be supported, and then after those critical jobs, there needs to be a time to decompress, because you need to process it mentally, or what we see is happening is people just can't come to terms, can't rationalise, don't have that support network within the service, let alone outside for assistance, and it ends in bad consequences. So.
And I have spoken with various paramedics too about the mental injuries that have occurred over the space of their career, because I couldn't imagine fronting up to work every day, you don't know what you're going to get.
Mm-hmm.
And I guess there must be a bit of fight or flight adrenaline constantly within those shifts.
Yep, definitely. Like, I think if you don't always know what you're going to, and I think if you're not in the headspace where you're thinking, what if and what am I going to, and a little bit nervous, then you're probably either broken or probably not suitable for the job. So even 22 years in for me, some call-outs are fairly minor by the sounds of it from the information we get either on our page or our in-vehicle mobile data terminal. So you could put it down as a blood nose from just a random thing. But then some jobs you'll go to where you'll get limited information, or it sounds really bad, and you'd start getting your hairs on your back and your neck up, and you're thinking, what if? And you don't really know what you're going into. A lot of those jobs will get support from the police just to be safe. But even still, every now and again you'll get a shock where you walk in and think, holy crap, like this is actually happening.
What does it feel like to save someone's life or to be in that situation? I mean, because our paramedics, I think they are incredible working under the circumstances, especially that they are. But
it's a little bit uncomfortable because we don't... I know personally I didn't get into this job to save lives. I got into this job because it sounded like it was going to be interesting. And when you realise that the job that you're doing does affect some kind of outcome, whether it's saving a life or whether it's just alleviating some pain or getting someone to somewhere where they need to be for their medical issue, whether it's minor or like a moderate issue. When you realise that, you'll get a lot of job satisfaction, and that's what you kind of feed off. From time to time, though, you will affect a treatment or a manoeuvre or something that will clearly be the difference between the patient surviving and not. It feels nice. Like it's what we train to do. It's not what we want to do every day, but when you get a chance to do your job and it's successful, then it's a next level job satisfaction.
do you feel like there's enough outrage from the community or people outside of the health system? Because I know sometimes until you're confronted with not being able to get an ambulance, then you realise, my mum, I need an ambulance on Christmas Day and couldn't get one. And that is not a slight at you or anyone there. It's
just resourcing.
It's resourcing. And hers wasn't thank goodness, life-threatening. But I thought about that day and I thought, what if it was? And everyone I feel we're all going to need, unfortunately, healthcare at some point.
I don't think they are angry enough. I think the resourcing shortages and the horror stories of people missing out on an ambulance and probably having a adverse event or death as a result of it are kept fairly quiet. I understand that's probably to do with some family kind of respect, I guess. But if the public knew on a daily basis how many crews were short and how many crews were single officers trying to do a job that two people should be doing, and the times that people not only wait for an ambulance but wait to have an ambulance dispatched, which is increasing by the week. Particularly last week was bad. They would be outraged, and they would be demanding more of the government. And we really don't want to go there, but if we need to, we will, because it's unacceptable, and that's not what we do in a first world country when we look after each other.
And as you touched on earlier too, it is a federal issue as well, because you've got people that should be in aged care homes in the hospital system, and aged care is looked after by the federal government. Disability services as well is under strain. I mean, it's mind blowing.
It's mind blowing. It's incredibly stressful for the workers and obviously for the patients. It just needs to be rectified, because if we don't do anything on the current trajectory, like when I'm 70, we won't have a health system. We won't have people that want to work in health system, because it'll be such a stressful, high pressure environment with zero support, and if we don't do something now, then that's what's going to happen. Simple as that. And you'll be lucky if you get an ambulance at all. And people will be throwing people in cars and taking them to the hospital themselves and waiting for 5 hours even just to get through the front doors. That's not what we want to get to. We need to fix it. We need to fix it now. Whether it's state government, sorting the hospitals out, sorting the ambulance service out, or the federal government stepping up and saying we've got to start looking after our old people a bit better and people with disabilities, then so be it. And they need to listen. I've never seen a workforce so angry and so upset. Ultimately, we'll lose them. And these are some smart cats that we need to have driving ambulances and attending to people.